Good afternoon, and thank you for staying. We'll try to crack on this last session, and hopefully it'll provide a wealth of new knowledge and information. It's my pleasure to introduce to the podium Mrs. Kate Lancaster, who is the Chief Executive of the RCOG. Kate has a long pedigree in healthcare management, having managed, being in a senior management of a position at Cambridge University Hospitals, and she's, apart from her role in the RCOG, she told me she's been a royal liaison with at the time in Cambridge, and she's also involved in the Sussex, Kent and Surrey innovative network for health. So she has a lot of experience. She's going to talk to us this afternoon on the role of the RCOG and how it can improve its involvement in Jordan and the region, because part of the RCOG is it's an international college and the global reach is very big. So over to you, Kate.
Thank you very much. I was just saying to Rani that anyone that stays this late in a conference really deserves a medal, so thank you very much everyone for staying. That's excellent. Given the very high quality of the clinical program at this event, I'm slightly embarrassed to be moving to a very non-clinical area, but thank you for the opportunity to just showcase some of the work of the RCOG. I'm really grateful for the opportunity. So, fine. No, I'll just use this one. Thank you. That's great. Thank you. Okay, so I'm just going to start by telling you a little bit about the RCOG for those that are less familiar. So we are a relatively small organisation based in London. We're registered with the Charity Commission, and importantly, we report into the Privy Council because we have a royal charter. So we're essentially connected to our royal family through a charter that was issued to us. We've got just over 18,000 members across 125 countries. So when we describe ourselves as a global organisation, it's not without merit. And a lot of the work that we do, given that we're a relatively small organisation with less than 200 staff, is actually working in partnership with other organisations, and this serves us very, very well. So continuing the royal theme, our royal patron is the Princess of Wales. She's very interested in the work that we do and is a frequent visitor to the college. Of course, she's been unwell for a little while, so we're very much looking forward to our next visit with her. So for those that haven't been there, we are based in Union Street. We have an absolutely fantastic building in London Bridge, and this creates the space for our activities, and particularly our learning activities. It's a purpose-designed building that has a huge number of features for education, including a digital studio and various other facilities. It's a very large building, and one of the things that we did when we developed that building was deliberately overspec the size so that we could welcome lots of other women's health organisations to join us in the building. And that's been really important. We are now the hub and the go-to place for women's health, and these are just some of the organisations that rent space from our building. And importantly, you'll see that we are also the home for the Royal College of Midwives, and particularly given the maternity services in the UK at the moment, that's very, very an important collaboration. So a little bit about what we do. We, as I mentioned earlier, are a professional organisation, but we exist to improve the health of women and girls across the world. We do that through the expertise and experience of our fellows and members, those that have MRCOG. And these are the particular activities that we are licensed through the Crown to do. So we set standards, and we talked a little bit earlier about some of the guidelines, and we encourage the study of obstetrics and gynecology, and that's another particularly important thing, is the next generation of doctors is always what we have our mind on. So in terms of where we are in the world, this just gives you a little snapshot of the countries that we work in and the areas that we work in and how our membership breaks down. So you'll see that we have roughly 50% of our members, roughly half of our members are outside the UK, and that's really, really important to us. Very much the ethos that we have as an organisation is that we learn from our overseas partners, and that's why meetings like this are particularly important, where we all come together globally and share expertise. A wonderful example of that, of course, is our Congress that was held in London, arranged by Professor Hassan Shahata, a huge successful event that brings together O&G doctors from all over the world. In terms of, this is a little bit tricky to read, but in terms of growth, you will see that overall our membership has grown by approximately 20% in the last 5 years. And you'll see the countries where it has increased and some where it has declined. And so we monitor this very, very carefully to see which countries we need to be focusing on and which ones are our priority areas. And you can see really impressive growth across the whole of the Gulf and Middle Eastern area. So that brings me to Jordan, and you'll see that at the moment we have around 85 members in Jordan, and this is how they break down. We also have 7 associate members. An associate membership is quite interesting. It's for 2 types of doctor. One where they already have an existing local qualification, they're very established in their career, but they want to be part of the RCOG family. They can apply to become an associate of the college, and that's very popular. Equally, doctors that are going through our examination pathway choose to become associates because they have access to all of our resources through that membership to allow them to be able to pass their exams more easily. And what we know is there's a direct correlation between candidates who have associate membership and higher pass rates. It's probably worth mentioning also that obviously Jordan, as we've heard a number of times, covers both Palestine and Syria. And we know that in Palestine we have just roughly about 15 members, and in Syria we now have about 6 members. So those are areas where we're looking to really increase our membership. So in terms of membership, I'm just going to talk about some of the activities that the college does. I mentioned that we'd grown our membership by nearly 20% over the last 5 years. Importantly, 96% of members continue their membership throughout their career, and that's a very important figure. We know that 690 doctors were elevated to fellowship, and that we've had around 29 membership ceremonies. I can't remember quite how many membership certificates Rani has now given out in her term, but it is a very significant number, and she has to hand sign every one of them, so very impressive indeed. I've talked a little bit about the types of membership. You'll be familiar with our membership, our fellowship. Retired fellows and members are very important to us. We know you have a number of those in Jordan. Being able to continue to contribute their expertise after they've retired is very important. I mentioned associates, and of course we had a mention earlier today of honorary fellowships. So our examinations, they are a really important part of the activities that we're doing, and I was on a call earlier today because we have exam teams flying out all over the world from this weekend, as we're going to spend the next 2 weeks running our Part 3 exam across the world in centres like Egypt. We have a new centre that's opening in the Kingdom of Saudi Arabia. We have exams in Pakistan, in Malaysia. We now have centres all over the world for our Part 3, our practical exam. In terms of our Part 2 examinations, though, we've got between 80 and 90 exam centres across the world. So we have a really significant footprint across the world. And here's some of the data, just to give you an idea of the exams that are taken outside the country now exceed those that are inside the country for us. And so you'll see the breakdown of the number of exams by exam centre here, and that's really quite important. So this is where our candidates are coming from. And you can see from this graph, this correlates very much with where you're seeing the growth in membership. Clearly, not everyone passes each exam first time. They are very, very difficult examinations, but it's really important to us, and we monitor this very, very closely in terms of our growth of examinations. And obviously we run, you can see the numbers here in terms of Jordanian candidates coming up that have taken the exam so far in 2025. Again, we're really, really proud of those numbers. So in terms of education, we've had some real success recently in terms of our new curriculum. Our 2024 curriculum is now embedded, and that's been a huge piece of work over a very long period of time. We've also had huge success in terms of our online learning. So our learning management system, RCOG learning, is one of the benefits of membership, both associate membership and otherwise, but it really supports doctors all over the world with their training and working really hard towards their examinations. Equally, we're particularly proud of our accreditation pathway. We now have accredited sites across India, in UAE, and various other parts. We've also just signed a very important contract with Malaysia. You might have seen on the slide that the number of members in Malaysia was declining. We've now signed a very important contract with the Malaysian Ministry of Health to undertake training of their doctors for the next 5 years, and that's going to reverse some of those membership numbers. So the accreditation area is something that we do a lot of. In terms of supporting our workforce, throughout this conference we've heard a lot about the pressure that doctors are under, and that's something that we've been very focused on recent years. We have a well-being hub on our website, and we particularly have an area to support international medical graduates coming into the country, into the UK. We know that's particularly a difficult transition for many people. Equally, we've got a lot in terms of peer support, and we do a lot of work in terms of awards and grants. Our courses and conferences are an area that we're particularly proud of, and we undertake around 120 courses each year. Many of those are also available online, so that doctors don't have to fly into the United Kingdom to do these courses, and they've been really important. A lot of this was kick-started by the very negative event that, of course, was COVID, but we actually embraced a lot of the technology, and it allowed us to then continue to provide those courses globally. Equally, we are also growing a lot of the courses that we provide in country. So we go overseas to provide some of the more practical courses in country, and that again is really important, particularly around some of the Part 3 examination courses. Really important to have some of those delivered face-to-face, so we've been allowed to do that. I mentioned the RCOG Congress. We are extremely proud of the congresses that we've held recently. We had an absolutely magnificent one in Oman, and really important for us to have one in the region. And then obviously we had the one in London this year. And again, every time we hold a congress, they get more and more ambitious. Thanks to Hassan, and this time obviously we ended up with 220 speakers across 7 streams, so really, really ambitious event. Clearly, as we look forward to the congresses, we've got 2027 in Kuala Lumpur, Malaysia, and then we're very proud to be having our next congress in Egypt in 2030 after that. So moving on, just trying to move this on. So then our global activity, in addition, all of the services that we provide as a college are delivered globally. But in addition to that, we have a global centre for women's health that is focused on philanthropically funded projects that happen across the globe. And some of these are listed here for you. Equally, we've got a lot of focus in terms of our FGM course, thanks to Hassan and the work that he has been leading. And a particular highlight in the last few years for us was receiving UN advocacy status, and that's been really important. We've been able to attend delegations in New York and really contribute to the global improvement in women's health, so we're particularly proud of that status that we've now gained. Clinical quality, this is probably one of the busiest areas of the college, producing green top guidelines, scientific impact papers, and a lot of the consent advice. Equally, we've had about £15 million worth of funding over recent years to look at a variety of improvement projects, from the Tommy's Centre through to our Avoiding Brain Injuries in Childbirth project. We're particularly proud of that one. That's now being rolled out across the whole of the NHS, so really important. Equal advocacy is a particular strength of ours and very, very important. We've done a lot in terms of the UK Parliament, speaking in Parliament, lobbying governments, really working with partners to make sure that the work that we do really drives benefit for women. What we know is we can train doctors, we can set standards, but unless we advocate for both women and professionals, the policies of governments don't change. So advocacy is a really important area of our work, and we put a great deal of effort into it. As a result, we've secured quite a lot of wins for women over recent years, and some of these are on the slide here for you. But we're not resting on our laurels. Moving into 2026, we've got a huge program of advocacy activity. So, we couldn't do any of this without our clinical leaders, and our clinical leaders for the past 3 years are on screen to show you now. It has been an absolute pleasure for us as staff within the college to be working with this absolutely exemplary team of officers. They have contributed their clinical expertise. They are all considered to be leaders in their particular fields, delivering their clinical expertise and leadership to key areas of the college, which have really driven the growth that I've just spoken about. And so it's a very sad day for us when we get to December, when we have to say farewell to this team of officers, but we're enormously grateful for the work that they've done. Equally, we'll be welcoming our new team of officers starting in December, and I've put these on the screen for you here. Again, really important transition year for the college, and these will be people that we will be introducing you to over the coming months. So just a little bit about how the college is run. We have a board of trustees that controls the activities of the college, and this is chaired by Baroness Tessa Blackstone, who sits in the House of Lords. Then within our council, just to give you the level of clinical input that we have within our college, these are the the elected fellows within our council, and these are the elected members within our council, just to show you what a clinically led organisation we are. And then briefly, obviously, we have the executive team led by myself. So now, looking to the future, innovation is a big area that we are looking to move ourselves into in the coming years. We have plans in place that have built over the last 2 years for an innovation hub, working with innovators and members who are looking to develop innovations both in digital technology and in the medtech area, not specifically in pharma, but in those 2 areas. And we've been working with our own national government and funders to create an innovation hub which will be new for 2026, and we're very, very excited about that one. We've developed, I'm just going to skip over those, but we've developed a strategy for the next 5 years, and these are the key areas that we will be focusing on for the next 5 years, really driving our membership ambitions, continuing the global growth that we have enjoyed over the last 5 years. We know that if we are going to improve the health of women and girls, we need more members to do it, so we're driving forward on our membership. We're continuing to have the gold standard. I'm often taken to task at meetings about why our exams are so difficult and why they are the most difficult exams in the world. we're very proud of the fact that they are so difficult and that they are the gold standard for what we do. And then, as I mentioned earlier, we'll be driving forward on our advocacy plans as well. So I'm going to pause there, but thank you very much for listening and making it towards the end of the conference.
Thank you, Kate, for this comprehensive review. Do you have any questions? Any questions?
No.
Do you have a question?
No. That's fine. Free to go.
No. Okay.
Thank you.
Yeah, Maher, yes.
Thank you, Kate. Excellent talk. And I think we should have had this talk early in the in the morning rather than late in the afternoon when everybody left, because it just gives an overview of a fantastic job that you all do at the Royal College, and we are grateful for that. So thank you very much.
Not at all. Thank you.
Now I will ask Professor Hassan Shahada to present his next lecture. We have the opportunity again to listen from you, Professor. Our next lecture will be about the role of immune system and recurrent miscarriage. Please, the audience is yours.
I will try to be as quick as possible. ماهر قال لي اختصر عشان الوقت. تعليمات. So, thank you very much. I was asked to talk to you today about the role of the immune system and immune therapy in recurrent miscarriages. But in order for us to reach that point, I wanted to highlight a couple of important points first. Number one, I would like to, first of all, as a declaration of interest, part of this talk I'll be mentioning progesterone, and I did some work for FIGO, where FIGO has received an unrestricted educational grant from Roche that was paid as an educational grant for the organization rather than the people involved in the study. So recurrent miscarriages is defined as 2 or 3 miscarriages before 20 weeks. Prevalence thought to be about 1% of all pregnancies, but we lack any guidance nationally or internationally on what should be the screening test that we do, and also what will be the appropriate investigations and the appropriate treatment. So I would like to start with thrombophilias. Now, this is the latest current RCOG guideline, which was published recently. And on this guideline, it very clearly said that there is a strong association with lupus anticoagulant and recurrent miscarriage. Second strongest is anticardiolipin IgG antibodies, and possible association with beta-2 glycoprotein, but very weak association with IgM antibodies. When you come to antibodies, it's really important to mention that the level needs to be on a high theta, not just above the normal range. So for anticardiolipin, we say above 40. For lupus anticoagulant, it needs to be on the 95th centile. What this guideline mentioned that there is a poor association between hereditary thrombophilias, such as factor V Leiden and prothrombin gene mutation, and the recurrent first trimester miscarriages, but there could well be a link with second trimester losses. So I've looked on the literature, what is evidence-based? And interestingly, when I looked on the data back to 1990, and I put on the study that we wanted a minimum of 100 patients on the study, I only found 5 studies that shows a link or studied factor V Leiden and recurrent miscarriages as defined as 3 or more. And these are the 5 studies, and clearly these 5 studies have shown that you get the same prevalence among the control population and the miscarriage population. And in our study, it was exactly the same. And you can see here very clearly that the forest tree there, it doesn't cross significance. So very simply, factor V Leiden is not associated with recurrent miscarriages. Now, this is very important for Jordan, because Jordan, part of the Levant region, you are one of the countries that has a very high prevalence of factor V Leiden. So please do not kid yourself by doing a test for a patient with recurrent miscarriages and you find factor V Leiden, assume that is the cause and go and start giving her aspirin and heparin, thinking that will reduce her risk of miscarriage. It does not. This is a fact. And the same applies for prothrombin gene mutation. We only found 5 papers back to 1990, and again, it did not cross the significant line. So prothrombin gene mutation is not a cause of recurrent miscarriage. Now, what about antiphospholipid? So we looked at it in our study, and we said, let's go with the old classification. If you have a positive lupus anticoagulant, once only, this is the before 1996, you would, on those days, you would classify the patient as positive, and the same applies for anticardiolipin. But even with that, you will find that the prevalence is very low. And if you go with the most recent criteria, which is 2 positive results, 3 months apart, you will only end up with 1% prevalence of patients with recurrent miscarriages showing that they have antiphospholipid syndrome. That's really important because if you look at previous studies, that the only 2 studies that have shown a link with antiphospholipid done properly showed the prevalence to be either 1 or 2%. Now, what is the prevalence of having antiphospholipid antibodies in the general population? It's between 1 to 5%, depend on the studies. So if you start testing the general population, you will have the same prevalence of antiphospholipid antibodies among patients with recurrent miscarriages. And therefore, it is simple to conclude that antiphospholipid syndrome most likely is not a cause of miscarriage. And I would recommend people to look at the new classification that recently have the International Rheumatological Association has come up with, suggesting that antiphospholipid should be removed from, miscarriage should be removed from a diagnosis of antiphospholipid syndrome. Now, we published this paper back in 2021 or 22, I think, before the guideline came out. And in it, we concluded that there is no evidence to recommend investigations or treatment of inherited or acquired thrombophilias. Now, you can say, well, this is just one center. But if you look at this important trial done by Professor Siobhan Quimby, which was published in The Lancet, and this actually was published in the same week when the RCOG guideline came out. Now, the problem you have with guidelines, the green top guidelines, you have to put a line somewhere when you look at references, because you need to write the literature. And unfortunately, the line was put about 9 months before the guideline was coming out, but during those 9 months, lots of other publications came out saying that do not really look for hereditary thrombophilias, and this is a very important trial, multicentral, international, hence why it was published in The Lancet, and they very clearly concluded that low molecular weight heparin does not result in higher live birth in women who had 2 or more miscarriages with hereditary thrombophilias, and therefore they advised against the use of low molecular weight heparin, advised against screening for hereditary thrombophilias. What about progesterone? So that's another important drug we tend to use. Look at this important NICE guideline where they recommended that women with recurrent miscarriages who have bleeding should be offered progesterone. And this is, they said, basically based on recent trials. But it's important for us to look at the trials that the NICE guidelines have based this on. So mainly on a trial by Professor Ari Kurisami, where he randomized patients into giving progesterone versus no progesterone. Very important paper, published in New England Journal of Medicine. We spoke earlier about publishing New England Journal of Medicine is not an easy thing to do. And very clearly, this study have shown progesterone does not improve outcome in patients with recurrent miscarriages. So we went back to 1990, and we only found 2 studies that look at progesterone versus placebo or conservative management. And at this time, we only looked at 50 patients. And we only had 2 studies. And guess what the other study was? It is your own Mazen Zibda. So this is a trial published by Mazen back in 2005, where he looked at hormonal support with oral dihydrogesterone. And in it, he found that maybe there is a slight increased benefit of giving that versus placebo. But the trial was quite small because there were only 90 patients. And therefore, statistical significance becomes a difficulty. So this is the literature. So what I concluded in that paper for FIGO, that progesterone has no role in recurrent miscarriages the way we currently give it from positive pregnancy test. The evidence does not support that. Despite that what the NICE guideline says, this is more expert opinion rather than evidence-based. So let's think what you normally do for your patients with recurrent miscarriages in Jordan or Egypt or even the UK. The first thing you think of is aspirin, heparin, and progesterone. Ladies and gentlemen, they do not work. Please do not screen patients for thrombophilias because it's an expensive test. I know it's very expensive in Jordan. Do not do the test. Do not look for factor V Leiden because most of your population will have factor V Leiden. So that's not the reason. What about the role of the immune system? Now, the reason I wanted to start with that is because one of the criticisms, and I am sure I will guess that Professor Yaqub Khalaf yesterday, talking about IVF and stuff, he probably had a dig at lots of other so-called add-ons, because I know his lectures are very typical, always covers this area. But the reality is, what we do on a daily basis does not work. So we need to think out of the box. We can't just be doing the same thing and expecting a different outcome. So do we think that the immune system have a role? And I'm a very simple man. I looked at the way that how in our bodies, if I receive a kidney transplant from my identical twin sister or twin brother, the body will reject that kidney transplant if I am not on immune therapy, correct? So why would the body accept an embryo that has half of the genetic material foreign from the father, and nowadays, with egg donation, completely foreign embryo? So if we accept that there's this special relationship between the immune system and pregnancy, it is not kind of a wide-fetched idea that sometimes a defect in that system can lead to problems. And that defect could either be an increase in numbers or an increase in activity. It's as simple as that. So, there are several immune associations, lots of studies links thyroid antibodies, anti-nuclear antibodies, gliadin antibodies, ENAs, toll-like receptors. So there are lots and lots of studies show there is a link. And I can tell you with confidence, there are more studies on the relationship between the immune system and recurrent miscarriages than factor V Leiden, antiphospholipid syndrome, and progesterone. So how does it work? So if you look here, the body recognizes its own cell. But if it looks foreign, it will attack it. So what do we know about the literature when it comes to that? So I have been very balanced here. The column on the left is looking at peripheral natural killer cells, where there is some studies shows benefit and some studies shows no benefit. And the column on the right is about uterine natural killer cells. And again, studies that show benefit and studies shows no benefit. So I can tell you, somebody who has been advocating for the role of the immune system over the last couple of decades, we have moved really from where the attacks were, this is rubbish, to now people arguing, yes, we accept the immune as a cause, but is it peripheral or is it endometrial? Now, the first study we did was actually back in 2003, and we found that there was a difficulty interpreting endometrial natural killer cells because we had different results, different stages of the cycle, say luteal phase and follicular phase, on the same woman, and sometimes we had different results at the same stage of the cycle at different months. So I'm a little bit skeptic about the role of endometrial testing, but I'm still open-minded about it. What about studies that report a negative or no association between natural killer cells? And you can see here the peripheral as well as endometrial. So what do we do if you have abnormalities? Prednisolone is a very well-known general immune suppressant that works against almost every autoimmune disease. If you have asthma, you have a steroid inhaler. If you have eczema, you have a steroid cream. If you have a kidney transplant, lupus, Crohn's disease, you name it, prednisolone works. It's a general immune suppressant. Hydroxychloroquine works through something called TRR7, TRR9, and I'm the first person in the world to start using it for recurrent miscarriages based on the work we had from the lupus, where we found that patients with active disease on hydroxychloroquine did better than patients on quiescent disease who are not on medication, and that improved their live birth. Intralipid, again, it has a role, and intralipid mainly is a nutritional agent, but has been found to detoxify things. So anesthetists use intralipids quite a lot when there is increased activity of a drug they want to neutralize. IVIG provides pooled antibodies, again, a general immune suppressant, and so is GCSF and anti-TNF alpha. So they are all drugs that people tend to use. But let's see what the evidence tells us. So this is a study by Siobhan Quenby in 2005, where she showed that prednisolone improves pregnancy outcomes if given at the time of ovulation. Another study by Biquet also showed that. But there are studies in 2019 and 2009 which showed that actually giving steroids doesn't really improve the outcome. Intralipids, very little research, to be honest. Even the ones that are positive are small. IVIG, I think there is a positive impact with IVIG, but the problem with IVIG is very expensive, and it's a blood product and needs a lot of monitoring. And I think at the moment we would normally recommend it only for research purposes. Hydroxychloroquine, lots of evidence, especially in patients with antiphospholipid antibodies. GCSF, there's a very big trial using Neupogen pens where they showed a positive outcome. And the same applies for adalimumab, but there are equally studies that shows a negative impact. This is a study we published where we looked at patients with IVF. I did this with Hussam Abdullah at the Lister back in 2005, and we found that actually patients with high natural killer cell CD69 activity had low implantation rate and a high miscarriage rate. And we went and treated the patients with steroids, and you can see here that we have that prednisolone appears to improve the pregnancy rate, especially in women with high CD69 activity. Without steroids, pregnancy success was much lower across both low and high CD69 groups. And this supports the idea that immune overactivity may contribute to implantation failure, and that steroid therapy can help suppress it. And this is our paper we published with regard to recurrent miscarriages, small numbers, but we found that patients with high CD69 had a higher miscarriage rate compared to those with low CD69. And when we gave them steroids, the outcomes were better on patients with the high CD69. This is some of the papers that we published from our group. So we published several papers in the field. So what do we do with the immune program? So very important to start with, I always give my patients extra vitamin D. In the UK, the current recommendation is 400 units. I tend to recommend 2,500 units. So I always ask my patients to have an extra 2,000 units of vitamin D. As you know, the UK were not really blessed with a lot of sun, and I think it makes sense to do that. And actually interesting, a lot of the European countries routinely give all their patients 2,000 units. There are several options depending on the condition. We use adalimumab, that normally comes in injections, 2 weeks apart. Prednisolone, you normally titrate the dose according to the patient's weight. I normally give patients less than 60 kilos, 15 milligrams, between 60 and 70, 20, above 70, 25 milligrams. Start at the time of ovulation. For 10 days, you do a pregnancy test, and if it's negative, you stop, and you start again the next month. If they're pregnant, they continue to 12 weeks, and then they wean off. Hydroxychloroquine, important also to titrate against the weight. If they're 60 kilos, we normally give them 300 milligrams. If they're less than 50, 200, and above 70, you give 400. You aim for a maximum 5 milligram dose per 10 kilogram body weight. Important to start pre-conception, 4 to 6 weeks, and you stop at 16 weeks. Make sure their eyes are checked, especially in the macula. Intralipids, we don't use as much, but if you do, then normally you give it before ovulation, and then when they're pregnant, every 4 weeks. GCSF, very rarely used, but if you do, again, you start at ovulation, and then every 3 days until they're 10 weeks. Now, one of the drugs I've recently been using is tacrolimus, but I mainly use it for patients with second trimester losses, in particular a condition known as chronic histiocytic enterovirositis, CHI, where you have a clear diagnosis coming from the placenta, from the perinatal pathologist, and you normally start by 1 milligram per 10 kilogram body weight. This is a drug we use a lot for patients with kidney transplant and kidney disease. Very well absorbed by the body and very well utilized, and it's very safe, but it needs expertise, and you need to be really working together on that aspect. Now, I would like to recommend that to read this paper we published recently. This summarizes all the work we've done when it comes to recurrent miscarriages, about the lifestyle, investigations, and the evidence, and the lack of evidence of what you do when you come to that. Thank you very much.
Thank you. Thank you, Professor Hassan, for this fruitful discussion. And now we will open the session for discussion. May we have a couple of questions?
About IgG.
Any question?
Thank you, Mr. Hassan. But about the IgG, don't explain how to give the IgG.
IVIG.
IgG.
Yeah. IVIG, I would normally say, first of all, it's intravenous, and people who use it, I don't use it. People who use it, they normally give it before ovulation, and then when you're pregnant every 4 weeks. I know some people give it every 2 weeks. The problem with IVIG is a blood product, number one. Number two, it's very expensive. It costs about £1,500 in the UK. That's about $2,000. And for me, I have never been convinced that it really works, or it has any, well, it works, but it has any benefit over the other drugs. So,
Give after conception.
where do you work? Where do you work?
I work in West Bank, Palestine.
So do you have access to IVIG?
Some doctors write recurrent abortion, give IgG.
I wouldn't.
But the problematic is high financial.
That's what I just said.
I want to sure is can give.
It's not something I would recommend.
It's not recommended.
No.
You can give prednisolone or another type
Yes.
of your this.
Yeah.
Yes. Okay.
But remember, my friend, immune therapy is a very serious drug. They are very serious drugs. So you need to have expertise to prescribe and oversee the medications. Because the complications are very high.
Excuse me, can I continue this discussion after, please, because we have to move on.
Thank you. Thank you.
Thank you. It's a pleasure to introduce a friend, Mr. Hani Fawzi. He's someone I've known for more than 30 years. He was my senior registrar when I did my first senior house officer job in the northeast of England. He taught me a lot of things. He taught me surgery. He had vision and drive to teach you and encourage you. And from that, he took it to the global stage. He did a lot of work for the third world, particularly Africa. He became the RCOG Vice President for Global Health. And now he's going to talk about the next stage of his life, which is retirement. Annie, over to you. Thank you.
Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. I think given the one before last slot, it really drives me a bit more, I feel I'm in danger, having to walk a very narrow line between really perhaps inspiring you and you slumber. I come to you today, a man who has retired. But in all fairness, I have been retired. I've got new wheels, heading in a new, different direction, but I hope I'm still powered with the same old, vibrant machine. In 2019, I have retired and left clinical practice altogether. After more than 3 decades of bedside, theater table, and I crossed to what many of my friends jokingly call the dark side management. I've done 4 years at FIGO, and I was director of projects, quite fascinating period, where I really learned that leadership is not about distance from the patients, but perhaps more about widening the circle of care. When that chapter closed, over the last 2 years, I took a sabbatical. Not to rest, but to reflect. I pursued an MBA, recently graduated, and began traveling again. Not with a scalpel in my hand, but with a story to share with you. You, my friends, embody the Arab physician's creed. الطبيب جندي في ميدان الرحمة. The doctor is a soldier in the field of mercy. We serve until illness overtakes us, or as our elders used to say, الطبيب لا يعزل حتى يعزله الله. The doctor is never dismissed until dismissed by God himself. Yet even as we laugh, we must acknowledge the truth. The world is changing. The concept of retiring is reaching our shores, and indeed, here into Jordan. And it invites us not to step down, but hopefully see as stepping forward differently. In the United Kingdom, where I lived for many years, retirement is an orderly ritual. There are forms, pensions, insurance, cakes, and the ceremonial surrender of the pager, the hospital pager. But at its heart, it's a society's way of caring for those who have cared for others. It says you have earned your rest. With respect to the payment, the pension is known as deferred payments. You have been paying for that as you were working. In our Arab world, the notion of is less financial and really more spiritual. Here we never retire from purpose, but perhaps only from position. We move from theater to teaching, from ward round to wisdom, from the clinical coalface to the corridors of mentorship. That, my friends, is the spirit I wish to celebrate, and it's the same spirit that our RCOG, particularly through its Retired Fellows Member Society, really wishes to celebrate and seeks to honor and to channel these efforts. The RCOG, through the Retired Fellows Member Society, gives structure to perhaps what our culture already understands instinctively, that retirement is not a full stop. وَبَعْد. It's an ellipsis, ... A pause before the next sentence of contribution. In the West, as you heard me say, retirement emerged from economics, the rhythm of industry. It was designed to make room for the younger workers and to protect those whose strength had been spent in service. It's linked to pensions, insurance, and the notion that productivity has a financial expiry date. In the East, particularly in our Arab and African worlds, the physician's identity is sacred, not salaried. We are measured not by output, but by al-barakah, the blessing of continued usefulness. A surgeon who still studies a trembling hand, a teacher whose voice guides the next generation, These, I'm sure you agree with me, are not retired. They're still serving with gentleness. When I first moved to London, I discovered that British doctors mark retirement with a small ceremony. There are speeches, a tea, a cake, and often shaped on an anatomical structure, and I'm sure you can think of the uterus. In Sudan, when we retire, we are more likely to receive another patient than a piece of cake. One system is economic, the other is existential, but both are really facing the very same question. How do we harness the wisdom of experience without exhausting the human spirit? This is where the RCOG's Retired Fellows and Member Society comes in, to offer a new language of professional continuity. It recognizes that whether in London, Amman, or Khartoum, there must be a place of belonging for those who have given their working lives to women's health. The Retired Fellows and Member Society provides that home, a community where the senior obstetrician can share mentorship, heritage, advocacy, and even humor. It's the bridge between the world of work and the world of wisdom. It transforms retirement from an exit into an entry point, a transition from practice to purpose, from production to influence. So what is this Retired Fellows and Member Society? My friends, allow me to introduce a society that many in our region may not yet know by name, but whose spirit I suspect you already live. It is the Retired Fellows and Member Society, for short RFMS, of the Royal College of Obstetricians and Gynecologists. In essence, it's the home of those who once stood daily at the labor ward's front line and who now wish to serve the vantage of wisdom. It embraces the retired, those in their late career, in the UK retired and returned, and honorary fellows. A community bound not by age, but by near, the intention to keep contributing. Roughly about 19% of the RCOG's membership belongs to this family, who may not wake on call nights anymore, yet will make the very same concerns. How are women and the newborns faring? Structurally, it follows, or it sort of is beneath the membership board, yet its influence stretches towards the Global Health Board, Education Board, and God willing, one day to the Council itself. Its mandate is simple: to convert experience into influence and service into continuity. If I may confess, in Arabic, we would call this society Majlis al-Hukama, a council of the wise. Not a retirement club of sleepy gentlemen sipping tea, but a living library of stories, scars, and successes. When I attended the first meeting for my Retired Fellows and Members as a committee member, I told my colleagues in the Arab world this society would have no members, as no one admits to being retired in the Arab world. They laughed, and one replied, then perhaps you should share it. That being the case, you'll ensure this society will never retire. And so here I am. My task as your colleague and as chair of this society is to turn nostalgia into legacy, and legacy into renewed action. My mandate has been just appointed in earlier this year. I accepted the honor of chairing the society. I stood on the shoulders of my esteemed colleague, Professor Jim Drive. I'm sure many of you might have known him through his time in Leeds, or as vice president, as an officer in the college. And he had, with his committee served with great dedication, and in all fairness, they have built the foundations, and it's our time now to really raise the arches. My mandate as entrusted by the college is both humble and ambitious: to refresh the society's purpose, to widen its reach beyond the UK, and hopefully to ensure that the voices of senior and late career professionals continue to guide the RCOG's moral compass. Our vision is in the formation, but I see it as really of three particular perspectives: to be a society of influence, a mentorship powerhouse, and a legacy honoring body. In Arabic, I would like to call these مجتمع الأثر والتعاون والعطاء, a community of influence, collaboration, and generosity. Our guiding question is simple: how can the wisdom of the seasoned heart serve the courage of the young hand? If we answer that, the RFMS will not only revive the retired, but hopefully rejuvenate the profession itself. Here in Jordan and across our Arab world, you already live this philosophy. Many of you mentor, teach, advise, and inspire long after your last on call. The RFMS offers a formal bridge so that what you do naturally becomes visible, celebrated, and connected to the global college. Together, we're keen to create a two-way current. Knowledge flowing from London to Amman and from Amman to London, ensuring that the RCOG truly remains a global college for a global community. As I often remind myself, service does not end, it only changes form. الخدمة لا تتحول، لا تنتهي بل تتحول. I want to share with you our theory of change. When we speak of change, my dear friends, we're not speaking of abandoning our past. We're speaking of giving it a new movement, حركة جديدة. The theory of change of the RFMS is in truth a story of how wisdom travels. It begins with a simple if, then. If you recognize senior professionals' value and build intergenerational bridges and create engagement, then we sustain the soul of our profession and the global influence of our college. To try and paint this to you as a journey in the traditional management style, our inputs would be the people, the institutional heritage, our commitment. In perspective of activities, mentorship, advocacy, advisory roles, heritage projects, global partnerships, and the list goes on. From an outputs, it's important to have visible engagement, documented mentorship, representation on boards. With respect to outcomes, a strengthened governance, an intergenerational trust, and renewed purpose. For the impact that we really want is really continuity of legacy and improvement of women's worldwide. In Arabic, we would say this, من الخبرة إلى الأثر, from experience to impact. For the value of wisdom is not in its storage, but is in its circulation, تصريفة. Like the bloodstream of a healthy body, it must flow to nourish the whole. The RFMS, therefore, is not a resting place. It's a conduit, a living artery within the college's body. When the pulse of its senior fellows beats, the whole institution feels alive. Someone once asked me, Hani, are you trying to make the retired busy again? I simply replied, no. I'm trying to make them contagious again. Contagious with enthusiasm, experience, and empathy. This, my friends, is our theory of change. Not statistics, but wisdom in action. الحكمة بالعمل. I'm going to share with you what we would like to have as a framework for our RFMS and 4 particular pillars. Every enduring structure stands upon pillars. The RFMS too stands on 4 pillars. We call them the 4 R's, each representing a discipline of renewal. They form a continuous arc, from rediscovery to recognition, from retention to rebirth. The first R is refresh. Refreshing identity and purpose. تجديد الهوية والغرض. We invite every fellow to rediscover their belonging. Retirement is not an exit from the college. It's a re-entry into a different room of the very same house. The second R is respect. Respect for wisdom and legacy. احترام الحكمة والإرث. We are the custodians of memory. Our pioneers, our teachers, our giants, their voices must not fade. Hence, the oral history and legacy archive within the RCOG library is a living gallery of stories. As Arabs say, "Man la madi lahu, la hadir lahu." He who has no past has no present. Our third R is retain. Retaining talent and influence. الاحتفاظ بالمواهب والتأثير. Too often expertise evaporates the same day the consultant hands in their keys. Through mentorship rosters, advisory panels, the RFMS will keep wisdom in circulation. Each retired fellow becomes a bridge between continents, sharing skills with younger colleagues, particularly in low and middle income countries. Thus, we convert legacy into a living capacity. And our last R is relaunch. Relaunching contribution in new forms. إعادة الإطلاق. For some, this means teaching or writing. For others, global missions or advocacy. The RFMS will craft bespoke roles, supporting the RCOG's international partnerships. The message is clear. You are not retired. You are repurposed. The retired fellows and members, the title in itself is renaming. We're very keen. Some of us do not like the name retired, and we're very keen to change that because semantics of legacy in some way. Words carry worlds within them. In Arabic, the Quran begins with Iqra, read, because to name is to give meaning. The name itself, Retired Fellows and Member Society, though honorable, whispers finality that our spirits resist. Retired in English suggests withdrawal. In our region, it evokes bewilderment. How does a doctor retire from mercy? كيف يتقاعد الطبيب من الرحمة? In the United Kingdom, retirement is tied to the economy, a moment of deserved rest after years of service. Yet in our global south, where pension systems are fragile, retirement simply does not exist. We remain قيد الخدمة, on duty until the candle burns to its base. And so the retired fellows and members is to speak to the entire fellowship of the RCOG, and as such, its language must reflect both these worlds. The evolution of terms are many. In all fairness, we're talking about Legacy Fellows and Member Society, perhaps Senior Fellows Forum, Circle of Lifelong Contribution, the Elders. Whatever it is, each title reminds us that the community is not a parking lot, but a platform. Not a museum of memory, but a movement of mentors.
2 minutes, please.
Thanks, Harry. When the hands grow slower and the mind grows sharper, the wise do not retire, they reposition. And that, I often say, once a doctor, always a doctor. What changes is not our identity, but our instrument. There are several opportunities that relate to what we can do when we do our move to the next phase. And in all fairness, I have shared with you those perspectives of what possibilities exist in the new coal phase. We have 2 events in the year. The next one is on the 28th of November, and it will be a hybrid, and I'll be very keen to pass on the details when we have our final program. There are 3 speakers, and you usually have 3 contexts of a global perspective, a clinical intergenerational dialogue, and the third one relates to a technical and a humanities lens. And my final reflections, my dear friends, as I look around this hall, I see not merely doctors, I see custodians of memory and architects of tomorrow. Each delivery we attended, each mother's heart beat we safeguarded has become part of an invisible lineage of compassion. Retirement then is not the silence after the song. It's the echo that keeps the melody alive. And now, how befitting is it to be here in Amman, city of eternal hills, where prophets once walked, where memory and modernity live side by side. The RFMS is built in the same spirit, rooted in tradition, yet reaching outwards. Let's therefore pledge to refresh our sense of belonging, to respect the shoulders on which we stand, to retain our collective wisdom, and to relaunch our service to humanity. واختتم كما بدأت بسلام على من جعل الطب عبادة، وسلام على من جعل العطاء عادة، وسلام على من لا يزال يعمل بقلب شاب وروح هادئة في شيخوخته. جزاكم الله خيرا. السلام عليكم ورحمة الله.
I thank you for a wonderful insight into retirement. Obviously, you put a lot of thought and effort into this. Does anybody have any questions? If not, can I ask you a question?
Please do.
Okay. So, obviously, in the framework of the working in the National Health Service, and we've got the President and the Chief Executive here, what you're mentioning, unfortunately, having spent a lot of time in England, does not apply to the work the government did to do things like job planning and all that kind of stuff. So what sort of thing would the retired person add to that? I just they couldn't wait to just get rid of them and get someone younger with a much less pay. So that's one major issue. The other issue is, I mean, someone like you is retired, obviously you're full of energy and health, and hopefully that continues. You can add a lot to the global state where there's a huge need in many world countries for people with your expertise. So where do you see this is going? Is it a developed world project? Is it a developing world project? Is it a hybrid? Your thoughts?
I think it's indeed a plan to be a hybrid. And in all fairness, we have just started the work. I know my predecessor has done a great work and built the foundations. I still have to form a new committee, and I'm very keen that we sort of look around and try and perhaps establish I mentioned our vision really relates to this intergenerational mentorship powerhouse and have an impact within the college's different departments. In that context, in all fairness, the world is our oyster. I think there is a lot we can do. We're very keen to celebrate our sort of retirement. Yes, it's a different purpose, different phase of life that hopefully intergenerational, the wisdom that we have ascertained, in all fairness, can help in many different ways. The NHS is evolving as well, and I think if we can organize ourselves within our college and hopefully have representation within the regions, then how we relate to our hospitals where we have worked for beforehand. There is lots of partnerships that can be initiated with the Tropical Institute, for example, and have lots of work that relates to mentorship in the low-middle income countries. I think there is a lot of opportunities. But
absolutely agree, and I think there is a college here that probably would want maybe help this project move forward, talking to politicians in it, because ultimately this work lies finishes with, isn't it? The ultimate decision makers.
Thanks.
Well, thank you for this amazing lecture. It's, I think you can say grand finale to a great congress, and it's a pleasure to introduce the next speaker.
Our next speaker, Dr. Suleiman Dabir, consultant in obstetric and gynecology, consultation of reproductive medicine, fertility and genetics, Al-Abdali Hospital, Jordan, Arab Board and Jordanian Board of Obstetrics and Gynecology, President of the Jordanian Society of Fertility and Genetics, member of the European Society of Human Reproduction and Embryology. Please, Dr. Suleiman.
Thank you, Mr. President and Co-President, Co-Chair, for introducing this, and thanks for everybody who stayed till the last moment of this Congress. I hope you will benefit some points from this lecture. Can we start? The first one, please, slide. Okay. My talk today will be about the use of LH in the stimulation protocols. You know that everyone تسهل عليه تسهل of stimulation protocols in IVF, as you know, is to produce more oocytes. And thus more embryos. You have better chance for embryo selection and maybe for freezing the embryos. We are faced sometimes with something called poor responders or poor ovarian reserve, in those cases who are aiming to father a child. What about the areas to discuss today is the LH window, how important in the induction protocols, about the role of LH in early and late follicular phase, introduction to the concept of poor responders, and we will say powers of Apollonia criteria and certain strategies, and the concept of hypo responders and the polymorphism, the role of LH polymorphism and recombinant LH supplementation in GnRH agonist cycle. I don't think we have enough time to go all these topics, but we try to cover as quick as we can some of these main topics in the induction protocols. What are the role of LH? So we are all concentrated on the use of SH in the induction protocols, but never talked about much about the importance of the LH in the induction protocol and the production of oocytes and the quality of the oocytes as well. In the early follicular phase, LH is important in promoting the androgen production in the TK cells. This action is synergistic with the granulosa cell production of estrogen, and we have the support dominance once FSH decreases. That means in the late follicular phase, sometimes FSH is not needed. Only LH is important and sufficient to produce to further production of the follicles. LH is also in the mid-cycle is important for the meiosis, resumption of meiosis, and the maturation of the cumulus oocyte complex, and is very important for the follicular rupture and granulosa cell luteinization. LH is also important in the luteal phase. It will convert the granulosa cells in corpus luteum body that produces the progesterone, important for, as we have heard, for luteal support. The concept of LH window, that means we need some LH important to be present in the follicular phase or the stimulation protocols. Does LH levels have negative effect on ART? As we have seen, many papers were studying the elevated LH levels, and they have a negative feedback impact on the induction protocols. As an high LH is not always good or not good, as you all know that LH is harm for the follicular genesis. What about the low LH level? Low LH levels as well as harm also for the follicular genesis. So high LH is not required and low LH is not required. Where is the window then to have the LH? One of the newest papers is published in 2025 about the role of recombinant LH reverse stimulation. What's new in these papers? Here we have the back to basics, the importance of the two-cell theory. As we have studied in the medical school, there is two cells responsible for the follicular genesis and the production of the hormones. LH is the most important hormone for the TK cells. So LH will stimulate TK cells and to produce androgens. Androgen will go to the granulosa cells in the follicles where FSH will work and convert the androgen these to by aromatase enzymes to estrogen. Estrogen will be produced from the granulosa cells and the cumulus of complex. Here is the two-cell theory. I will not go into details of that, but it means you need the LH first to convert to androgens, then it will go to the granulosa cell where estrogen is produced. So you need estrogen in the early, LH in the early follicular phase as well as in the late follicular phase. What are the levels of the LH? As here, again, the two-cell theory and the importance of the two-cell theory in producing the hormonal profile of the follicles to produce the acid. What about the induction protocols? We have now new induction protocols where they will interfere with the hormonal profile of the folliculogenesis. So giving LH or giving agonist or antagonist protocol, it will interfere with the folliculogenesis. And here the LH receptors, LH granulosa cumulus receptors will develop when the follicles are more than 10 millimeter in growth. Isn't different protocols with different hormonal profiles. As you have seen here, if you use the agonist or antagonist protocol or the natural cycle, you have suppression of the LH hormones. Sometimes in the antagonist protocol, it is less suppressed than agonist. Agonist is much suppressed, as the green light shows us on this slide. And we have the hypo, they are very suppressed, that we have no LH at all. So natural cycles, as you see, the LH is different from early to mid and late follicular phase, but the cycles what we are using for stimulation protocols, it will interfere with the levels of LH. What levels of LH we need to focus on? What is the therapeutic level of the LH? If we are in the between the lines, as you see here, we have normal follicular growth, we have normal androgen and estrogen biosynthesis, and we have normal oocyte maturation. What about high LH? If we have a high LH at a certain point where there is suppression of the granular cell proliferation, there is follicular atresia, that high LH will cause harm to the follicles. You have premature luteinization, and so as well, if LH threshold is low, you have a very low LH, there is follicular growth is impaired, inadequate androgen, as we have seen in the two-cell theory, and you will not reach the full oocyte maturation. What are the ceiling and the threshold of the LH? As you have seen in this slide, LH should be less than 5 international units per liter, and the threshold should be more than 1.2 international unit per liter. This is what we call the therapeutic window. When we induce our patient for folliculogenesis, we aim to stay within these ranges. Many papers and many studies, they use HCG instead of LH. Does HCG work the same as LH? Some doctors or some physicians, they add low levels of HCG in the induction protocol, aiming to have better prognosis for the folliculogenesis, but HCG is not as well as LH. As you see, if we use recombinant FSH and recombinant LH, we have better results than using HMG. HMG, it has HCG in very little amount, but it is not as good as recombinant LH use. So LH is bad sometimes. It should be controlled. It's important, can be harmful. It should be replaced in some cases. Is there a need for recombinant LH hormone? This is the question that we are talking about today. Which patient will benefit from adding LH? Is the composition primary endpoint of follicular development, and it gives you a better quality of eggs. As you can see here, the hypothalamic pituitary axis, that mean can be hypothalamic disorder, either pituitary disorder or both. What about if we treat the patient with recombinant FSH alone in hypo patients? Patients with hypohypothyroidism, they have no LH at all, but if we treat them with FSH alone, we see that the levels of estradiol are very low. That means they will not produce enough sufficient of LH because we have seen the two-cell theory, we have low estrogen. But if we give them the hypohypothyroidism with LH, if we supplement these patients with recombinant LH, we see the levels of estradiol are rising high. This is here, where you have a higher estradiol levels if you supplement the patient with recombinant LH. That means the role of recombinant LH in those patients is very crucial to support the stimulation protocol. We get back the follicle development in hypogonadal patient, give back what they are missing. Again, the thresholds, as we have seen, should be less than 5 international unit, and the minimum is 1.2 international unit to have better folliculogenesis. LH is precise, is consistent, half-life is 24 hours compared to the HCG. HCG have a longer half-life that will not compensate the role of LH in folliculogenesis. Then who will benefit from LH supplementation? Aged group, patient with higher age group, they prove to be initially poor responders. Follicular stagnation, that means during the stimulation protocol, the follicles stop growing, and low responders, patients, and the last category is what we know as LH polymorphism. That means if you even give LH, the patient will not receive or will not recognize the LH in the follicles, or as we call LH receptors polymorphism. So these are the categories that they need supplementation of LH, especially the poor responders. What about women with more than 35 years of age? The number of functional LH receptors with age decreases. Endogenous LH may become less potent biologically. The only group for benefit from LH supplementation with an increase in the number of mature eggs collected, improve implantation rate. What about the poor responders? Poor responders as well, they may benefit from the addition of LH, especially if they show they have low response in the stimulation protocol. If the patient are taking enough hormone FSH, but still the follicles are not growing well, so the addition of LH during the stimulation protocol, it has a benefit. It showed that addition of these hormones are very important. The beneficial effect, especially in poor responders, if they proved that they are poor responders in previous cycles, so the addition of LH is essential, especially if they reach more than 3,000 units of FSH and the suboptimal response less than 4 oocyte, and the number of follicle, they are high, they have good number of primordial follicle, but the follicles are not growing properly. The follicle should grow between 2 millimeters in 3 days. If this is not achieved, that means LH receptors are not sufficient on the follicle. Then how they found the optimal dose of LH? Here they have many studies done using different protocols between 25 international, 75 and 225. As you've seen in this slide, that the dose of 75 international for LH added to the stimulation protocol, or 225 international, they will have the same results. So the minimum dose required of LH is 75 international units added to the stimulation protocol. We can use also 150, especially if you are using 2 types of injections, one with LH, but 75 it's enough to do the job. Is there a risk of adding LH sometimes to the stimulation protocol? If the patient, yes, if the patient is receiving high doses of FSH, the maximum, and you add LH, you should take care of not to have ovarian hyperstimulation syndrome or multiple birth if you are not taking care of that. Benefits against the risks, if you have optimal folliculogenesis, convenience, safety profile, high pregnancy rate is the patient deficient in LH. One big conference was on the LH supplementation in the Pacific Asian area, and the whole conference was about the addition of LH. Adding LH, especially in patients with agonist protocol, long protocol as we used to call it, these patients, they may benefit from adding some LH. it showed that it has improvement in the pregnancy rate and significant ongoing pregnancy rate, and you have more frozen embryos in these cycles. What about poor responders? If they are produced less than 3 oocytes, we call them as poor responders according to Bologna criteria. If they have between 4 and 9 oocytes, they are hyper-response. Is between 4 and 15 oocytes. The optimal is 10 to 15. We call them that's good responder. This is our aim to get on this. If they are more than 15 oocytes, they are high responders. There's many opinions about these response according to Bologna criteria, and then they are modified, the Bologna criteria, to what they call the Poseidon group. Poseidon group is a concept that they put patients in different categories, in the age categories and age groups, and they put that with these patients, they can do better with addition of LH. And now last 2 slides about Bologna criteria, and we have discussed this before. This is the Poseidon group, where you have 12 professors. They call the Poseidon group because patient-oriented strategies encompassing individualized oocyte number. And there are many people, and the last slide for tonight is Poseidon group 1, Poseidon group 2, and these are the groups where you can differentiate the patient between the age and the previous response according to the group, where you can schedule your patient to start FSH and LH from the start, or just supporting LH during the stimulation protocol. And by this, I will finish my lecture for today, and thank you very much for staying so long.
Thank you very much, Doctor, for this important lecture. Yes, if you have questions, Dr. Omar.
مساء الخير. Thank you, Dr. Sliman, for your nice lecture. As an experienced colleague, if you have a patient willing to start a program while she's from Poseidon group 2 or 4, would you prefer to start HMG from the beginning using a high dose, or to start recombinant FSH and then think of adding LH later on if the response doesn't satisfy your intention?
Thank you, Dr. Omar, for this good question, really. HMG, I can't compare it with recombinant LH. So with recombinant LH, usually you have better response compared to HMG. The problem in our patients or our society is the cost. When you tackle with the cost of LH, recombinant LH is triple the price of HMG. That's why we go sometimes to start with HMG. But if you are patient, if you're willing to start recombinant LH from the start, especially Poseidon group 4, I will start LH from the start of the cycle. But I am the person who measure LH 2 or 3 times during the induction protocol. So not one time. Many colleagues, they don't measure it, or they measure 1 time. But I would prefer to measure it 2 or 3 times during the induction protocol, especially in those category of patients.
Next question, Dr. Falah.
I think I have a good experience with dealing with induction of radiation. I think urinary HMG is as good as recombinant. And everybody who can convince me that recombinant is more effective, I will say, no, it's not true. We've been doing this and doing that, it is the same. And the advantage of urinary HMG is that you have the FSH and the LH. And the idea of giving whether the agonist or the antagonist protocol is to suppress the LH cell to prevent premature LH cell. So anyone who advocates that you give the recombinant FSH, which is double or triple the price of the HMG, urinary HMG, is not really convincing, because overall you want to have a reasonable price where the patient has to pay for it. You know, we don't pay, but the patient will pay the price for the drug. I think the recombinant FSH is a copy of the FSH and the LH, isn't it? It is a copy of it.
Thank you,
But if
Dr.
have
Falah.
the urinary FSH
What's the question, Dr. Falah? What's the question, please?
Dr. Falah,
What I'm saying that the LH is there and the HMG we give from urinary HMG, it is there. Why to look for whether to give or not to give? I understand that probably in hypo with very low FSH and LH to start with.
yes, Dr. Falah, I get your point.
Urinary
You are
HMG
going
is
back.
as good as the recombinant, and then you have to add this. It's not very true. You know,
I get your point. You are going back to basic teaching. That's HMG, it has FSH and H, but it's not what we are telling today. العلم اتغير, يعني changed now. You have subgroups of patients. Let me tell you one point. You have subgroup of patients, they will not respond to HMG, neither to FSH. Especially the patient is going on the cycle, at day 6, there is 10 follicles without response. What you will do? They are not growing. Even you give her another 2-3 days of HMG, the follicles are not growing. You have two options. They are LH receptors polymorphism. That means there is LH, but it's not working because you have different type of FSH LH receptors. Or these patients, they lack of LH because of agonist protocol, long agonist, they lack of LH. LH is important for the two-cell theory and the growth of the follicle. If you stop, you stuck. But most of the patient, what you are telling is correct. This is most, but you have subgroup of patients, they will stuck, they will not grow follicles anymore if you don't give LH supplementation.
Okay, well, thank you very much for all this nice debate. You can continue later. And I'd like to thank you for sticking to time. Congratulate you on this great lecture. And thanks for everybody who stayed for the afternoon. And Dr. Mazen, the chairman of the Congress, would like to have the final word.
Thank you, Suleiman. Good evening, everyone. And I know it is too late, and we have only, I'm just saying one small word. First of all, I would like to thank every one of you who's staying up till now, and my sincere thanks and appreciation for Professor Rani Thacker and Kate and my colleagues. I know Dr. Abir has left because he was called for an emergency in the hospital. As you know, over the last 2 days, we have 33 lectures which covered nearly all aspects of obstetrics and gynecology. And some of the lectures maybe were the first time to be given in Jordan, like those on robotic surgery. Also, the artificial intelligence talks which were presented, I know it is a breakthrough in medicine and everywhere in all the specialties, and I'm glad that Professor Fogarty, I think, he spoke about artificial intelligence. Dr. Maher, thank you also for your help and your support, and many thanks for all of you, and I wish you safe return back home. I know tomorrow you are going home, or you're staying. So, yalla. Thank you very much. And I know the sponsors have left, so still, some of them are still outside. أولا أنت الكبير فينا.